Well, hello and welcome to 125 Hearing Disorders, and we are talking 2019. Today, I believe, is June the 6th. Let's see to make sure I've got that right on my calendar. Yep. And it's 11 a.m. my time, hopefully 1 p.m. your time, not in Central Time anyhow. We're talking outer ear and middle ear disorders today and next week for sure. So we'll probably spend on this unit outer and middle ear disorders, kind of those sort of go together. In a couple of weeks, we'll look at inner ear disorders of the cochlea and hair cells and things like that. Noise-induced hearing loss, presbycusis, Meniere's disease, all of those delightful little cookies. After that, we'll look at retrocochlear pathology. In other words, pathology of the eighth nerve, the nerve going from the cochlea to the brain stem. And there's not many pathologies involving the brain, the central nervous system, except learning disabilities. In other words, you can hear, you just can't listen, okay? Focusing attention is more of a brain thing. So that's a little bit different again. But at any rate, just want to make sure we've got our recording happening, our videos all happening here before I start getting lost in the notes. So, and then we'll actually even look at pseudohypoacusis. In other words, faking hearing loss. People who fake a hearing loss for no reason or for various reasons. They have reasons, usually financial, sometimes psychological. So, in a nutshell then, outer ear disorders, middle ear disorders, inner ear disorders, retrocochlear pathology, and then pseudohypoacusis, faking hearing loss. And essentially, this runs the gamut of our hearing disorders course. It's only an 8-week course. It's shorter than most of our courses are, being a summer semester course. I would imagine some of you are also taking 150 hearing aid fitting methods, something totally different, but focus closely on that course as well, because that too is a short course, and that introduces you to the fitting methods. Now, next semester, and I think around next year in 250, I think in the winter semester of 2020, I'll be teaching fitting methods again, kind of sort of, fitting methods in real ear. So 150 and 250 kind of go together. 150 is in the summer, and then 250 is 2 semesters later. Not the fall semester, but the winter semester of 2020. Enough about that course. Back to this course, HEAR 125, Hearing Disorders. So why don't I share screen here and share screen and pull up our lovely little, see if you're looking at this, and we'll go into documents here. I'll just show you, give you an idea as to what it is exactly that we are covering in this course. And just kind of wade in here slowly. 125, and here we are. Now, look at that. Final exam quizzes, aren't that fun? Now, we really won't be looking that much. I'll blow this up and make it bigger. We won't be looking that much at this, Unit 1, Air Conduction, Bone Conduction, Tympanometry. That's if the course was longer. That's why I'm saying not used, okay? But we are looking at Unit 2 today. Hawk is a physician, ear, nose, and throat doctor. He's got a whole gallery of pictures of the tympanic membrane or eardrum, various outer ear pathologies. We'll look at that. Unit 2, the notes, outer and middle ear disorders. Unit 2, PowerPoint, outer and middle ear disorders. So we'll be looking for the first 2 weeks at this unit, at these 3 PowerPoints that I'm circling here. Then we go to Unit 3, inner ear disorders, its notes and PowerPoints. Then Unit 4, its notes and PowerPoints, retrocochlear pathology. And then pseudohypoacusis, faking hearing loss. Again, its notes and PowerPoint. Tinnitus we will not cover in this course. There's not enough time. Okay, so the Unit 6 won't be covered and Unit 1 won't be covered. We'll be looking at outer and middle, inner ear, retrocochlear, pseudohypoacusis, in that order. All right, having fun? Good. All right, we'll move up to the top. Over to here. Okay, Let me know if you can't see this, but basically there it is. Audiometry, outer and middle ear disorders. I have no idea if your Martin textbook has these things in these particular chapters anymore, because there's more editions of Martin than you can shake a stick at. So basically, I couldn't count on that, but you can look in your contents and read about outer and middle ear disorders in your textbook. You'll find it. Okay, the notes are what I always take as a shortcut. Kind of that's where the most dense material really is, in those notes. So follow me here in the notes, and we'll take a look at this. Outer ear disorders: microtia, small, abnormal outer ear. Anotia, no outer ear. Now, these are going to be genetic, people born with a problem this way, okay? Atresia means the ear canal isn't all there, okay? The cartilaginous or the bony portion has not formed, and that's found often in Treacher-Collins syndrome. Look at the spelling of that. Treacher, like teacher, but with an R. Collins with 2 L's. Treacher-Collins syndrome is hereditary. The cheeks and facial bones are not well formed. They are often born with microtia or anotia and atresia. Now, you can get acquired atresia, which is atresia means a closure of your outer ear canal. Let's look at a picture of that. No, not that one. Let's look at, let's see, I'll make this one smaller. And I'll make this one smaller, and I just want our PowerPoint. Okay, I've got to, oh, here it is. There you go. We'll go home here, and here's a picture of atresia. So if you can see that, okay, you're looking at a closed outer ear canal. Small, weird-looking outer ear. Here's atresia and microtia. Now, this person has Treacher-Collins syndrome. He's wearing a bone conduction hearing aid. Look at this. It's stuck on the mastoid bone. So you're delivering sounds by bone conduction. Here's a young girl with atresia and Treacher-Collins syndrome, and she has a bone-anchored hearing aid. They actually opened up the skin in the back behind her ear and implanted a very small magnet that was screwed into the skull, much like a thumbtack, where the point was the screw that went into the skull a little bit, and then the flat part of the thumbtack, okay, is underneath her skin, and it's a magnet. And then this has a magnet as well, and it sticks to the magnet under the skin. So you're never puncturing the skin anymore, but you're sticking the hearing aid on top of the magnet that's underneath the skin. And you're delivering it, once again, the sound through bone conduction. Why? Because you can't use air conduction. There's no ear canal. So you can't have sound going down an ear canal to hit the drum. There ain't no ear canal. So you have to deliver the sound by bone conduction. Very trippy, but different, okay? Let's look here at the notes. A stenosis, that's different now. That means a partial closing of the outer ear canal. Partial. It doesn't cause much hearing loss. Here, what can be an example of stenosis? A partial closing, as opposed to a total closing. Earwax can cause a partial closing. Okay, earwax does cause a slight hearing loss, but not much. If you can see past the earwax, okay, there is no hearing loss. Anything jammed in an ear canal to partly block the ear, maybe a kid stuck a little toy, a bead inside the ear canal and can't get it out, the eraser of a pencil. Okay, something stuck in the ear canal that's partially blocking the sound, but not totally, won't cause any hearing loss at all. It's only if you've got atresia, a total closure. Excuse me. You can have external otitis. You can break the word down. Oto, ear, itis, inflammation. External, outer. Outer ear inflammation. Maybe you've been tickling your ear canal too much with a Q-tip. Maybe you've been sticking a bobby pin in your ear canal to itch it. Maybe you've been fussing around in there too much and the skin gets swollen and irritated. Okay, external otitis, inflammation of the external auditory meatus. Swimmer's ear, a fungal infection from water trapped in the ear canal. Myringitis, look at the word there, okay? Look at the word, itis, inflammation of the eardrum. Myringotomy, by the way, we'll look at that word too in just a bit. Osteoma, a bony tumor. Oma always means tumor, okay? Every time you see the word Oma, doesn't mean grandma in Dutch or German, it means tumor, okay? An osteoma is a tumor in the external auditory meatus, a bony tumor. I'll show you pictures of all these things in just a sec, okay? Sometimes seen in those who swim in cold water. Cerumen, earwax, produced by glands, now read this carefully and underline it, in the cartilaginous portion of the external auditory meatus. The cartilaginous portion, okay, the part that you can wiggle, the outer half of your ear canal. That's where hair grows in men's ears, and that's where the wax glands are, okay? The inner part of your ear canal is as smooth as a baby's behind. There's no hair there, there's no wax there at all, unless you've pushed it there with a Q-tip. Because wax grows on the outer portion of your ear canal. And that's why doctors always say never push in your ear, because you're jamming wax where it never was even in the first place. You're pushing it deeper in. Cerumen, produced by glands in the cartilaginous portion of the external auditory meatus. The hearing remains normal as long as the otoscopic exam reveals a visible tympanic membrane. As long as you can see behind the lump of wax, there will be no hearing loss. You have stenosis, a partial closing of the ear canal, which does not, repeat, not produce hearing loss. It's only when there's a total blockage. Audiologists are now being trained to remove cerumen. Sometimes also hearing instrument specialists can take a course to remove cerumen. We don't normally teach it at OTC, nor is it taught by IHS, International Hearing Society. But there are people coming around that do train in cerumen management. Generally, I'm not trained in it, but you can remove wax from the very outer portion of an ear canal. But when an ear is impacted by wax, it's best to refer to someone who can take it out. Okay. Besides, that's why you always look in an ear canal before doing a hearing test. Always do an otoscopic exam to look and see if there's ear wax in the ear canal. Let's face it, the outer ear is the biggest and the part of the ear, and it's the part that we have direct access to. So that's something we should always tell ourselves to do, is look in an ear canal before doing a test. Tympanic membrane perforations from trauma or middle ear infections. Perforations in the bottom portion of the eardrum heal faster than others because epithelial skin migration is faster at the bottom of the drum than it is from the top. Now I'll stop sharing for just a second here, okay? Skin grows from the middle of the eardrum out, and then it migrates out the ear canal, slowly but surely, okay? So your earwax tends to naturally be migrated out. So skin migration, you've got a growth of skin in the eardrum, doesn't stay the same all your life, okay? There's always skin growing out, and then it continues out along your ear canal. There's always a bit of a migration happening there. Back to sharing screen. Okay. Look at these three words here. Once we finish this little section, I'll take you to a PowerPoint where we can look at pictures of all of these things, okay? Migration is encouraged with cigarette paper over perforation. That's right. Sometimes a doctor will actually take a bit of cigarette paper, rolling paper, and lay it across your eardrum, the hole. Lay it across the hole that you might have a perforation in your eardrum. If you have a pinhole perforation in your eardrum, that will heal by itself. But if the hole is too big and won't heal by itself, often they lay a bit of a tissue, a cigarette paper, or some type of a scrim on the hole, over the hole, so that new skin can grow over it. Okay, they lay it as like a plate for skin to grow over and therefore heal the perforation in an eardrum. The middle fibrous layer of tympanic membrane tissue. Now, remember the eardrum from anatomy. It has 3 layers. There are 3 layers, right? Remember that? Ectoderm, mesoderm, endoderm. Okay? The outer layer is continuous with skin on of your ear canal. The middle layer is that tough fibrous layer. They sometimes call it it's like a spider web. It's like spokes in a bicycle tire. From the center, from the umbo, growing out like spokes, like an asterisk. That's that middle fibrous layer. That's the tough layer that makes your eardrum stiff. And then you have the inner layer, which is continuous with the mucous lining of the middle ear space. That's endoderm tissue. The middle layer, mesoderm tissue, the one that forms bones and muscles. It's that layer. And then the outer layer, ectoderm, which forms skin and nerve tissue. Anyway, middle fibrous layer of tympanic membrane tissue does not migrate well, so healed perforations always remain weak. Okay? You may have what they call a monomeric eardrum. Look at this at the bottom. Monomeric eardrum, a thin tympanic membrane due to imperfect healing of perforations. Or you might have tympanosclerosis, a thickened eardrum due to scarring and calcium plaques. And that'll form because of repeated bouts of otitis media. Ah, there's another one. Otitis inflammation media, middle ear infection. And we'll cover that. We'll start into that today as well later. Okay? So, repeated bouts of otitis media will cause a scarred tympanic membrane because maybe it perforated and then it healed again and perforated and healed again. Okay, but even if they use a cigarette paper over the top of a rather large hole, it'll heal the bottom layer, the endoderm, and the outer layer, ectoderm, but the middle layer won't heal very well. And that's why the eardrum will be in that area, not very stiff. And that's what was meant here earlier. The middle fibrous layer of tympanic membrane doesn't tend to migrate so very well. So healed perforations tend to remain a bit weak. Myringotomy, myringoplasty, tympanoplasty. Let's look at the terms. Myringotomy, a hole or a puncture made in the tympanic membrane by a doctor, done to suck out fluid from the middle ear, from OM, otitis media, otitis media. Okay, myringoplasty, a surgical repair of a perforated tympanic membrane. Maybe they laid that cigarette paper over the hole and let the skin grow back. Sometimes they'll use vein tissue. Might work better than skin tissue to lay across the hole and make a patch. Okay, fascia, tough fibrous tissue covering muscles. They might extract that from somewhere on your body and lay that across the tiny eardrum. Okay? Tympanoplasty, surgical reconstruction of any middle ear structure. Tympanic membrane reconstruction, maybe with grafts for a totally blown out eardrum. Maybe they'll use a metal or plastic prosthesis device to replace missing ossicles. Maybe the malleus is screwed. Maybe the incus is screwed up. Maybe the stapes is screwed up. They'll try and make a prosthetic device to replace those. surgeons try to attach existing middle ear structures together. Maybe they'll attach the tympanic membrane directly to the top of the stapes bone, if it's not worthwhile or possible to create a new incus and a new malleus. Okay, so without any further ado now, let's look at some pictures of some of this. We'll go to here and find out where we can find out just a few pictures. This picture here, of course, was atresia. Treacher Collins. Osteoma, look at these, tumors of the ear canal. Here's the eardrum, and you can tell this has got to be the left ear, because look, the cone of light is at 7 o'clock. If it was the right ear, the cone of light would be at 5 o'clock. Did you know that? You should. Okay, so here's swimmer's ear. Maybe the person swam a lot in cold water, and the body naturally tries to protect the ear from cold. And so these non-cancerous, they're benign, but bony tumors start to grow to try and protect the eardrum. Isn't that weird? Osteoma. Osteo, bone, oma, tumor. A tumor from the bony portion of the ear canal. The inner portion. Remember, cartilaginous is on the outside. The bony portion is medial, or on the inner half. Here's soft earwax. Okay, very soft earwax. And look, you're in the outer half of the ear canal because you can see hair. And this is soft earwax, but look, you can see behind it. There's a little bit of a hole there. And that hole means there's no hearing loss. Sound can get around that wax. That's not a, but it can easily plug up if you jam a Q-tip in there. Here's old, harder wax. Look at that, it's darker, okay? And it's because it's got more dirt and debris. But once again, it's a stenosis, not atresia. Look, you can see through. I see the eardrum. I can see you, all right? So anyway, let's go to here. Let's see if I can show you a picture. Here's a myringotomy. Here's the eardrum. And here's the, I guess this would be the tensor, pars tensa, pars flaccida. This would be the manubrium of the malleus as seen through the eardrum, the umbo right here. And they make an incision, and they'll suction out some of the fluid from otitis media, middle ear infection, behind the drum. They'll suck that out. And then they'll put in a little spool here through the hole. And that's a PE tube, pressure equalizing tube. And that forces the eardrum to stay open, because that's done for otitis media. Look what it says. A myringotomy incision on the left. B, a pressure equalizing tube positioned through the eardrum to allow for middle ear ventilation. Maybe the eustachian tubes from the throat weren't letting new air come into the middle ear space. Remember the middle ear space. I'll show you here. The middle ear space, it's as big as a sugar cube. Just a little, as big as this, okay? With the malleus, incus, and stapes behind it, or inside of it. Eardrum on one end, malleus, incus, stapes ending at the cochlea. Little space. And that space is normally filled with air. And the air in that middle ear space should be equal in pressure to the air outside. In other words, the air pressure on both sides of the eardrum should remain even Steven, okay? If the air pressure is the same on both sides of the drum, your middle ear is going to work the best. Remember what your middle ear is for. It's a transducer. It's changing energy from one form to another form. And what's it doing? It's changing sound waves, compressions and rarefactions. Remember the waves from acoustics? It's changing sound waves into mechanical energy. And energy can't be created or destroyed. It can only be changed from one form to another. And then the cochlea, remember, is going to take that mechanical energy from the footplate of the stapes that's moving in and out of the oval window, And the cochlea is going to change that energy into hydraulic wave energy again. Not sound wave energy, but water wave energy. The basilar membrane is going to be moving, remember, from acoustics, and then you get a traveling wave. And the wave, if it excites the apex of the cochlea, you hear a low frequency sound. If the wave stimulates the base of the cochlea, the wide base, you hear a high frequency sound. All of this from anatomy, okay? So anyway, so the ear is literally a series of transducers. The middle ear transduces sound waves to mechanical energy. The cochlea transduces mechanical energy into hydraulic wave energy. Hydraulic meaning water-like waves. Transverse waves, remember, as opposed to longitudinal waves, which are sound waves. And then the hair cells of the cochlea transduce that water wave, that hydraulic traveling wave energy. They change that into electricity. And electricity then runs up the eighth nerve to the brain, and Horton hears a who. Okay? So that's literally the series of transductions. Middle ear, sound to mechanical, inner ear, mechanical to hydraulic, and then hydraulic into electricity. So anyway, so now let's go back to sharing screen. And where was we? All right, here you go. Myringotomy. And by the way, have we got this down? Okay, this is a picture of what I showed you earlier. A right tympanic membrane, shown on the left. And you can see its cone of light is at 5 o'clock. When you look at a left tympanic membrane, the cone of light is at 7 o'clock. And always remember, the cone of light is just simply the reflection of light off your otoscope. And a healthy eardrum should show a cone of light. And the air pressure is even Steven on both sides of the drum, then God's in his heaven and all's well with the world. This is another pressure equalizing tube shown as opposed to a penny. So you're looking at it's fairly small. And we can talk about Otitis Media next, and kids, we'll get into that in just a second here. But let's just kind of take first a peek at the other PowerPoint slide so we can look at even more pictures. Okay, so here we go. All right, there's a hairy tragus on the left. Men tend to have hairy ears, especially older men. Okay, and look where the hair mostly grows, right around the tragus, the outer portion of the ear canal. You may even have to trim first with a scissors if you're going to take an ear mold impression of that guy's ear. All right, get used to it. Isn't it special? This is a real hairy ear. All right, here's atresia. There's a mild developmental abnormality of the pinna, the ear, and there's been a complete failure of canalization of the external auditory meatus. In other words, there's no ear canal. Surgical reconstruction may be successful if there is an erect, a normal middle ear to be found. Maybe they did a CAT scan and they found out that the middle ear exists. There's just no ear canal. Well, then they can do surgical reconstruction to create an ear canal. Here's a normal right ear tympanic membrane. Okay, you can see the cone of light at 5 o'clock, manubrium of the malleus, umbo. You can even see the long process of the incus. And then you can see the neck of the stapes through it. So the eardrum literally, here's the annulus, the outer ring of the eardrum, and skin normally migrates from the center out. Think of the eardrum like a bathroom window. It's translucent. You can kind of see shadows through it. You can't see, it's not transparent, but it's translucent. Light can get through it, and you can see sort of shadows, but that's about it. Here's another normal tympanic membrane. Okay, cone of light again at 5 o'clock. Lots of vascularization. That's healthy. It's not reddened really. It's just okay. Decent eardrum. A close-up. Look at it closely. Ah, we have Nicole showing up here. Great. All right, I see that. Okay, so you're taking a look here. Normal eardrum. Now you're looking down into the canal a little bit, and you can see the hairy portion of the outer or external part of the outer ear canal. And you can see where the wax grows, again, from the skin of the cartilaginous portion of the outer ear canal. And when you go in further now, this on the right, you're looking with an otoscope is deeper in, and you're seeing the eardrum closer up. And notice the skin becomes smooth. No longer are there any hair follicles there. Earwax doesn't normally grow there at all. This is how skin is shown to be migrating, literally wrinkles. As the skin migrates laterally, okay, let's see if I can move this guy. As the skin migrates laterally, it eventually reaches resistance in the form of the hairs of the cartilaginous portion of the canal. This traffic jam actually leads to piling up of the skin and development of wrinkles as seen. Weird, huh? Now you're looking in closer again. You can certainly see, all right, again, the wax forming. Wax is a mixture of blah, 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 don't worry about it, debris and secretions of the ceruminous glands of the cartilaginous portion of the canal. Always remember, wax grows from the cartilaginous portion, not, repeat, not from the bony portion. And that's why jamming with a Q-tip only serves to push the wax further in. Ceruminous glands are located in the lateral, outer, hair-bearing portion of the canal, and they secrete their product around the base of the hairs. There's nothing wrong with earwax. It's there for a reason. Remember from anatomy, it's a bit of a bug retardant. Okay, bugs don't like it. Here is a stenosis caused by, let's see if I can move this out of the way. If I can move this guy. Oh, it won't let me move it this time. Ah, there you go. The actual appearance of wax in any individual depends on the type of cerumen secreted, the amount of keratin and blah, and the amount of dirt. However, cerumen is secreted in two basic forms. The moist, soft, brown wax, the wet form, is shown here, is the most common. Now, a doctor or a nurse or a practitioner can push in a curette and actually get behind this and pull it out. Some people use water, the water pick, and they'll shoot water in here, warm water, that's sterilized water, and you have to know how to do this. You can't just shoot it in and hit the eardrum. The person will be screaming in pain. But you want the water to kind of make the wax loose, and the person holds a kidney dish by his ear, and the wax falls out into the kidney dish using water pressure. So there's various ways of getting rid of wax. The curette is the most common. Earwax. There's a great variation in the color of normal earwax, shown from golden yellow on the right to almost black. Here's stenosis, another form of stenosis. This kid put a bead in his ear, okay? A plastic bead was found in this young child. They had to actually put the child to sleep under general anesthesia for removal due to lack of patient cooperation. Whoa, this is rarely, if ever, required for foreign bodies in adults. Syringing with water is often useful for foreign body removal. Again, using a water pick or something like that. Just to highlight the fact that the term stenosis, as we covered earlier, a partial closing of the canal, whether man-made or whether natural. Okay? Here's another type of stenosis. Let's have a bug in your ear. Bugs would love to go in your ear. It's 98.6 degrees Fahrenheit in there. Real nice and warm. Why not? Okay? So here's a, look at this. If the foreign body occludes the ear canal, pain and bleeding if there's been local trauma, and in this case an acute otitis external outer ear, oto ear, itis inflammation, external, produced by local irritation of the skin. The underlying cause for the problem became apparent after treatment. Yeah, no kidding, after looking in. Ugh, gross. Here's an abrasion of a canal. Okay, we're looking today at outer ear pathology. Let's just look at this so you really get an idea of what you're seeing. Okay, this person's been picking around in his ear too much. Okay? An abrasion produced either by medical cleaning or more frequently by a cotton-tipped Q-tip. And the skin of the ear canal is very tender. Very tender. Often things look worse than they really are. But if a client ever saw this with a video otoscope, the person would freak. You would probably freak too if you look in, but it's often man-made. Here's a hematoma, in other words, a blood blister. With really aggressive use of Q-tips, evidence of even more severe trauma can be found. In this case, a large blood blister has been the result. This can precipitate an otitis externa. In other words, this can cause an outer ear infection. Again, look at the words and break them down. Oto, ear, itis, inflammation, externa, outer. Here's outer ear inflammation, another type. Okay, acute means it really hurts, it's sudden. Inflammatory condition infecting the skin lining the outer ear canal. It most often occurs as a quick infective dermatitis, skin, itis, infection, with a blah, 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 blah as one of the most common infecting organisms. Early stages, severe otalgia. Circle that word, oto, ear, algia, pain, ear pain. There's a visible swelling in the skin, giving this typical follicular appearance and early serous discharge. Well, early discharge of non-infectious fluid, in other words. Here's bony exotoses. Another cause of compromise of the external canal are bony exotoses. These rarely cause problems with hearing. Look, sound can get in there, not a problem. They are due to or migration. The skin can still migrate out, as we said earlier. They are also due to excessive bony growth as a result of stimulation of the canal by frequent exposure to the cold, especially swimming. Remember I mentioned that earlier? Bony exotoses, swimmer's ear. Here's an osteoma. Okay, in contrast to exotoses, okay, which are just lumps formed by the bony portion of the canal, because you have to remember these are bony exotoses, okay, in the inner half of the canal. This is different. Osteomas are rare benign tumors of the temporal bone, usually lying in the external ear canal. If they occur, they are more likely to warrant surgical removal, as they more frequently can completely compromise the canal. In other words, they can more frequently cause not stenosis, but atresia. So these are a little bit different, okay? But these are bony exotoses, and this would be an osteoma. Swimmer's ear, a tumor. Now here's a person had an ear infection, and you've got it now, perforated eardrum. Although given enough time, 3 to 4 months, most cases can resolve spontaneously and require no treatment. In persistent cases, and with those with a hearing loss, surgical treatment is required, which involves insertion of a ventilation tube in the hole. The first step in this process is an incision in the eardrum or a myringotomy. So what happens here, in this case, the otitis media, the doctor decided to perforate the eardrum, remove the infectious fluid from behind the ear, and then put in a tube. Now here's a traumatic perforation of the drum. Result in sudden changes of air pressure, or maybe the person got punched in the side of the head or slapped against the ear really hard. Okay, in this case it was a result from a blow on the side of the head. Here's otitis media. Now the infection is behind the eardrum. So you're looking down the ear canal. This is ear canal, and here's the eardrum. There's the umbo, but it's literally bulged out like your cheeks. It's literally doing this. Stop sharing. It's doing. The middle ear is filled with pus. Remember we said the middle ear is as big as the tip of your little finger. And now it no longer has air in there. It's filled with pus. Otitis Media. Oto, ear, itis, inflammation, middle. It's called earaches. And kids get earaches. And earaches they get. And the reason they get earaches, and the reason we don't get earaches as much as adults, is because of the shape of our heads. Your head grows taller and your jaw grows outer. Little kids have squat heads and the jaw is more in. When you have a small head like a child, the tubes, the eustachian tubes from the back of your throat, where you get a sore throat, a tonsillitis, infection of the tonsils, that infection can crawl up a child's eustachian tubes because the child's eustachian tubes are fairly horizontal. And they go right up the eustachian. Here's by the tonsils. This is at the middle ear. When you get to go through adolescence, the eustachian tubes become more vertical. Your head got longer. And because your eustachian tubes are now more vertical, you've got gravity working on your side. You don't get middle ear infections as easily anymore. It's children that get more middle ear infections. And middle ear infections are called otitis media. And we'll really look more at the stages of otitis media next week as well. But otitis media is the biggest #1 problem of the middle ear. It's the most common pathology or disorder of the middle ear. So back to our notes here. Share screen. So this is otitis media with pus. This is almost exclusively a condition of young children and is an acute bacterial infection of the middle ear. The first changes are usually redness of the drum and a slight swelling, particularly the upper portion, the pars flaccida. Can you think of why? I can. The reason why is because the pars flaccida is least stiff. It's the pars tensa, the large part of the drum, that's the stiffest. Remember when we talked about this in anatomy class? Pars flaccida, the top of your eardrum, the little thing between the nodes of Ranvier. Look at your anatomy notes. The eardrum is a big pizza pie, okay? But there's a part of the eardrum, and I'll just draw it quickly here for you so you can see it, okay? When you're looking at the eardrum, the top of the eardrum, pars flaccida. Pars tensa is the whole other part. This part has thin skin. It doesn't have the middle fibrous layer. Okay? It's thinner. And this part can actually accommodate tiny changes of air pressure, the kind of tiny air pressure changes that might occur if you walk up a flight of stairs. Okay? It accommodates small changes in air pressure. If the changes get bigger, then you have to literally blow your nose or equalize the pressure another way. All right? So that's really what you've got to think about here. So share screen again. All right. Acute otitis media. As the condition progresses, the middle ear fills with pus, causing the drum to bulge to the side, out. Here's mucoid otitis media with effusion, glue ear. This is as opposed to acute. This one's chronic. Look where my cursor is. It's prolonged, recurrent otitis media, again and again and again. It's the most common cause of mild to moderate hearing loss in children. The slide shows the classical appearances with a dull appearance to the tympanic membrane and the loss of the light reflex because the cone of light isn't quite as much, indicating that there is fluid in the middle ear and basically that there is a bit of retraction, but it's called glue ear, just like what you would imagine. Old, cruddy, not really acute, like quick, hard infection, but kind of like a long-lasting, basic kind of lining of crud and crap and goop along your middle ear ossicles and the entire middle ear space from recurrent bouts of otitis media. Here they're showing you fluid that's been sucked out of the middle ear. It's thick, it's infected, gives it like a glue-like consistency. Here on the bottom is more like serous otitis media. Marked in contrast to the infectious type, which is yellowed, this here is watery fluid, and this is like early otitis media. The fluid isn't infected yet. Serous means the fluid like underneath a blister. You ever have a blister and you pop a blister and the fluid comes out, it looks like water. It's not infected yet. Serous otitis media happens before infectious otitis media. Here's serous otitis media, okay? Result of eustachian tube dysfunction, and we'll talk about what happens here, but you're getting thinner fluid behind the eardrum. It's not infectious yet. Here, they've blown into the ear a little bit, achieved by performing a forced expiration with the mouth and nose closed. They had the kid plug the nose and mouth and make the ears pop. And the air in the middle ear here can be seen in the form of bubbles. Check that out. Okay, here they know they have fluid. They wanted to prove it. So they had the child plug his nose and blow really hard to pop air into the ear, into the middle ears. Because what happens when you're doing that, think about it. Stop sharing screen. When you do that, you plug your nose and your mouth, you're forcing air up the eustachian tubes. You're forced, because remember the eustachian tubes are constantly closed unless forced open. They open for a second when you swallow. When you're chewing gum, when you swallow. When you yawn, they open up. And then they close again. The reason they open up is to allow new air into your middle ear. Your middle ear spaces are always absorbing oxygen. And your eustachian tubes need to open once in a while to let new air get into your middle ear space. And if no new air can get into your middle ear space because your eustachian tubes are closed all the time, and what's going to make that happen? Sore throat, tonsillitis, swollen, sore throat due to a flu, a cold, or whatever. And now the bottom of the eustachian tubes, here at my fingertips, never opens. Even when you swallow, the eustachian tubes don't open when you swallow because they're swollen. And if they're swollen shut, your middle ear space, that little sugar cube air-filled space, gets bummed out because oxygen is always being absorbed by the lining of your middle ear space. And now, because the oxygen is always being absorbed by the lining of the middle ear space, you're getting a vacuum because no new air can come in through those eustachian tubes when you swallow because they're swollen shut. So the first stage of otitis media, sore throat. Second stage of otitis media, your eardrums become sucked inward, retracted, sucked in because of the vacuum, because your middle ear is always absorbing oxygen. Third stage of otitis media, serous, S-E-R-O-U-S, clear, non-infectious fluid begins to fill the middle ear space. That's the middle ear's reaction to the vacuum, okay? The middle ear's reaction to the vacuum. Serous, clear, non-infectious fluid begins to bulge the eardrum. Stage 4, the serous otitis media becomes pus. And pus is white or yellow. So the serous has now become purulent. Let's spell that word, okay? Write it down because it's in your notes, but I just want you to write it down. Purulent. P-U-R-U-L-E-N-T. Might have 2 R's. Purr, like a cat. Purr. Purulent. Okay, P-U-R-R, I think U-L-E-N-T, purulent. Or another word for it is called suppurative. S-U-P-P, but not E-R like supper, okay? S-U-P-P-U-R, suppurative, A-T-I-V-E, suppurative. Purulent, suppurative, same thing. Infected or pus-filled middle ear. Okay, so otitis media has chapters. Sore throat, vacuum behind the retraction now, serous otitis media, purulent or suppurative otitis media. And what's the treatment for it? Myringotomy, suction out the fluid, put a tube in the kid's ear, especially if he's always getting otitis media. You know why? Because if the eustachian tubes aren't going to open, the doctor will say, screw it, let's put a hole in the eardrum and keep so that air can get in there. So you can never get a vacuum. So otitis media won't happen because you'll never get a vacuum in there. You've got a permanent little man-made hole in the eardrum made by the PE tube. So they made a little incision, myringotomy, suctioned out the fluid, stuck in a tube to keep that there. Now remember, the skin of the eardrum migrates. So that tube will fall out after a couple of months. It will fall out. And good, then you're done. Tubes aren't used all the time. Antibiotics is a treatment for otitis media. Okay, but we're becoming, immune to our antibiotics. So antibiotics are not always the first thing of choice. Okay, the second one is tubes. All right, and the third one is tonsillectomy. Sometimes they'll just remove the tonsils. If they remove the tonsils, they won't get swollen. And then the eustachian tubes aren't as blocked anymore. So there's various ways that doctors treat otitis media. But otitis media causes hearing loss. And what kind of hearing loss? The same kind of hearing loss as wax does. Conductive. Conductive. Okay? A blockage of sound being conducted to the inner ear. So middle ear pathology and outer ear pathology cause conductive hearing loss. Always remember that. There's two types of hearing loss, conductive and sensorineural. Sensorineural is damage to the cochlea or the eighth nerve. Can't fix it. Humpty Dumpty fell off the wall, Humpty Dumpty had a great fall. All you can do is wear hearing aids. Conductive hearing loss can be surgically fixed. Remove the wax or get rid of the infection. Okay? Conductive, always think of pathway. Okay? A physical, mechanical blockage of sound getting to the cochlea. When you have a problem there, you can't hear by air conduction, but with a headphone. Okay, because a headphone is delivering sound by air. And it's delivering the sound and it's getting blocked by the wax or blocked by otitis media. Okay, but bone conduction, put your hand on that mastoid bone behind your ear. Then you deliver sound through bone conduction. Someone with conductive hearing loss will hear like a baby. No problem. Bone conduction will be normal, okay? Totally normal. Air conduction will be impaired. That's how you, as a clinician, are going to tell what type of hearing loss someone has. You're going to do they have conductive or sensorineural. Let's see what this chat was. I'm on and do not have a cam, but I can hear you. Oh, that's good to know. All right, not a problem. Good stuff. So let's share screen for the last time here, and we'll take a peek-see at our notes. All right, just take a bit of a peek at our notes and see where we've gotten to today. So, audiometry and outer ear disorders. Outer ear disorders can be painful due to pressure from the headphone when you're testing somebody. Outer ear disorders can result in mild conductive hearing loss. In other words, blockage of the ear due to wax. Remember, though, it's got to totally block. It's got to be atresia, not stenosis. Remember the differences between atresia and stenosis. If you can see behind the wax, there is no hearing loss. Lots of outer ear disorders have no associated hearing loss because there's only stenosis, a partial blocking due to wax or whatever. Audiometric results for outer ear disorders. After tympanoplasty, let's say they repaired a hole in the eardrum, they've repaired something. Maybe the ossicular chain may be interrupted because they have a prosthesis in there, so things may be not totally right again. High frequency conductive hearing loss is caused by partial discontinuity of the ossicular chain. Soft connective tissue grafts sometimes transmit lows better than highs. They have mass. Says here, watch out for collapsing ear canals, mostly seen in elderly who lose cartilage. Now I'll stop sharing for just a second and just talk at you. You got an elderly person and you're putting headphones on his ear. Circumoral headphones, you know, the big ones that sit on the ear. They're losing cartilage. Now, cartilage is the stuff at the end of your nose, okay? Cartilage you see in chickens when you're eating a chicken and you see that cartilage sticking out of the bone, okay, of the breastbone or the whatever on a chicken, okay? So here, this is cartilage. This is cartilage. When you're elderly, you're losing cartilage. So if you put headphones on, you will collapse the ear canals. They won't stay open because you're using pressure against, and there's not enough cartilage to keep the ear canal open. So when you've got collapsed ear canals, Houston, you're going to have a weird problem. You're going to be having a high frequency conductive hearing loss, which is highly unlikely when due to natural causes. Highly unlikely, and I'll show you what I mean here on a picture, okay? But here, just in your notes, what I want you to read for next time, look at Otitis Media and look at the stages. Look at the stages. Look what I just said, what we just covered today, okay? Exactly what we covered today. So we got up to here. Next week, we'll continue from here. Okay, let's look at some pictures though of what can happen with otitis media and kids. Their eustachian tubes are more horizontal. An adult has more vertically aligned eustachian tubes. An adult skull is longer. A child's skull is shorter. That's why they have more horizontal eustachian tubes. That's why they get more middle ear infections and earaches. So here's young Johnny, 7 years old, 6 years old, more prone to ear infections. There's the eustachian tube going to the back of his throat. Here's that little middle ear space, malleus, incus, stapes, eardrum, outer ear canal, and the cochlea. He's going to have a lot more ear infections than this person will. A normal tympanogram, or tympanic membrane, which one is it, right or left? You should say right, because the cone of light is at 5 o'clock. A normal tympanic membrane again. Retracted tympanic membrane due to otitis media, stage 2, the vacuum. Notice how it's sucked back and it's laying on the promontory, which is the mound of bone between the oval window that the footplate of the stapes fits into and the round window below it. Well, that's gotta hurt. I mean, here's the eardrum. And it's part of it is just sucked back. There's that serous otitis media when the child was asked to hold his nose and close his mouth and blow hard and force air in, and you could even see the air bubbles. Acute bulging. Now you can see it's white. Okay, here the fluid is serous, it's clear. Here it's white. It's suppurative or purulent. There's those words. Another example. Another example. A pressure equalizing tube. And again, it's a non-medicinal way to work around the problem of constant recurrent otitis media. And let me just show you something here in your notes. Okay, go up in your notes and look here. Seen in 70% of American children before 2 years old. Half of these kids experience it again and again. More common in males than in females. Really common in First Nations, Aboriginal people. Less common in African Americans, but begins with a sore throat. It's a big one. It's very, very common, and some children have constant bouts of otitis media. Constant. Let's look and see if we can find an example of what it looks like here. I'm going to see if I can scroll up and find a classic. Here it is. This is classic audiogram of otitis media. Let me move this away. There. Okay. Right ear is the O's. Left ear is the X's. Notice how the hearing loss is fairly flat. It took 40 to 50 decibels for the child to just barely hear through the headphone. Take the headphones off and put the bone oscillator on the mastoid and look at how the child hears out of both ears like a baby. Okay? Conductive hearing loss. A hearing loss, a moderate degree, 40 to 50 decibels of hearing loss, and it's flat, because you should always think of conductive hearing loss as a plug in the ear. Always, always, always. Conductive hearing loss, whether it's caused by wax, whether it's caused by pus in the middle ear, is always to be construed and considered as a plug in the ear. In fact, when you put earplugs in your ear, you are giving yourself a conductive hearing loss on purpose. You're mowing the lawn and you want to protect your ears from noise, and you're putting earplugs in, you're giving yourself a conductive hearing loss on purpose. You're blocking the passage of sound getting to your inner ears. Good. You're smart. Otitis media, however, isn't voluntary. This kid's got a plug, and the plug is called pus. And the pus has got to be taken out so that when they test the hearing again, the X's and O's are laying up here. Okay? So otitis media, conductive hearing loss. How much hearing loss does wax cause? A little bit. Or this is due to external otitis. Ooh, I wish that thing would go. Due to external otitis. Okay? Slight hearing loss. Here's what you might have with collapsed ear canals. I'll move this out of your way. Here, the hearing loss in an adult with presbycusis. And we'll talk about presbycusis later on in the course when we get to inner ear pathology. So next week, remember, we're still spending it on outer and middle ear pathology. So tune into the very same notes and PowerPoints as you did today. But notice here, bone conduction is better than air conduction. You've got a high frequency, what we call air-bone gap, a slight conductive hearing loss in the highs, which is very unusual. Okay, and that's caused by collapsed ear canals during air conduction testing, the elderly person. And their hearing loss is usually sloping down, okay? Most inner ear pathology slopes down. Most conductive hearing loss is flat, because conductive hearing loss is literally a plug in the ear. Of course, you will remember this. Hi, I'm stapes, the tiniest wee little bone in your body in your middle ear. Sound waves entering the ear canal vibrate the malleus, the incus, then me. And he gets more excited. And I stomp on the oval window to send the signal to the inner ear. I am the all-powerful stapes, and your audio perceptions are at my mercy. Anyhow, otitis media. We'll talk much more about it next week. I just want to make sure we've covered everything here. Just look into where we got to go. Yep, we did. All right, let's stop sharing, and we'll call this one a day. And we will meet again this coming Monday, and Monday is going to be the 10th at the same time, 1 p.m. Central Time. 11 a.m. Pacific time, my time, okay? So basically, we will always be meeting on Mondays from now on. We just had to get going this week. I was gone this week on Monday. That's why we held our first Zoom session for 1:25 today. But from now on, it will be Mondays at 1 p.m. All right, I will stop recording now.